if you're having heart symptoms, please see the cardiologist. Get worked up.
Absolutely.
Make certain that is ruled out first.
Absolutely.
Okay? Because we want to rule out the things that could kill you. So
no doubt.
Rule it out.
Yeah.
But then when they find nothing, it's time to see a menopause specialist, especially if you're in your 40s and 50s or even late 30s. It's time to go to the next step, and don't wait for your doctor to recommend it, because he probably will not.
Exactly.
She actually also may not, but he is definitely not going to recommend it and still isn't aware of it.
Welcome to Clitorology, intelligent information about women's sexual health from leading experts in the field. I'm Jacqueline Buckingham, founder of the Women's Intimate and Sexual Health Foundation, CEO of Huge Pussy, the activist brand changing the meaning of pussy, and your host. Every week, I bring you the top physicians, plastic surgeons, sex therapists, gynecologists, psychologists, our nation's chief clitorologists, and the most renowned medical experts and thought leaders in the field of women's sexual health. We'll also talk about intimacy and how to have your best sex life, because we know sexual health is connected to mental health and longevity. Having intelligent information means a better life for us all. But women's sexual health has some catching up to do. So it's time to tap into your huge pussy energy and get ready for class, because learning about women's sexual health is healthcare. Welcome to your new favorite subject. This is Clitorology. Welcome to this important episode that delves into a critical yet overlooked aspect of healthcare, the heart health of women. Today, my guest is Dr. Jayne Morgan, a renowned cardiologist and outspoken voice leading the charge in creating awareness for women's risk of heart disease, especially during menopause. In a world where women's health concerns are frequently sidelined, and disproportionately when it comes to cardiology, where the research on women is thin at best, Dr. Morgan's insights are not just timely, they're essential. Through her research and clinical experience, she sheds light on how women can access accurate diagnoses and effective treatment for heart-related issues that can be life-saving or life-threatening. Today's episode is not all life and death, though. Jayne and I laugh and share stories about our own heart-healthy practices as well as the not-so-heart-healthy ones. Mostly, we're exploring the intersection between women's health, heart health, and menopause, a nexus often overshadowed by misconceptions and disparities in healthcare. Dr. Morgan's expertise enlightens, empowers, and has sparked meaningful conversations, like the one we're about to have about the urgent need for gender-inclusive approaches to heart care. I couldn't be more honored that she's here. This is an episode you don't want to miss for the sake of every woman in your life. Let's dive in with my friend, the unstoppable Dr. Jayne Morgan. I've learned so much from you specifically about heart health. And that's what we're here to talk about, is heart health in women,
That's right.
Heart health and menopause, heart health and actually getting educated about what it is and how we can take those cardiac prevention measures to keep our hearts healthy.
Right. And why is it a secret? Why is it a secret? Right.
Honestly.
Why am I even having to come and talk about it? Why is it a secret?
Well, that's what it's felt like every time I've listened to you, is I'm like, why don't we know this already? Why isn't this common knowledge? So we do associate heart attacks with men.
That's right.
What I've learned about women is that it's a really slow kind of a thing that can go often unnoticed.
Right, I call it a slow burn in the book that I'm writing.
Thank you.
That chapter is called The Slow Burn.
Yeah. So what is the slow burn?
And so the slow burn for women is symptoms of which we are not aware because we don't associate them with heart disease.
Yeah.
So chronic fatigue. What woman isn't tired sometimes, or you're tired all the time and you just think, oh, I've got to get more rest. Chronic fatigue or nagging back pain. Million reasons to have back pain, right? So you've got these non-specific symptoms. Or jaw pain, which is not often that common. And it might actually, if it's severe enough, send you to the dentist for an oral exam when in fact you might be having a heart attack. Sometimes instead of having pain in the left arm, you have it in the right arm.
Really?
So you're not really concerned about it. You might have flu-like symptoms that you just can't shake, a cold, a flu that you can't shake. All of these kind of non-specific symptoms.
Okay.
As you move through it, you delay seeking medical care,
Yeah.
right? Because, I'm just going to rest. I'm going to take some cold medicine. I'm just going to push through it. I'm going to get some more sleep. I don't know why I'm tired. And then your heart is just becoming increasingly under stress. That's why a woman's first heart attack is often fatal, more often fatal than a man's first heart attack because of this slow burn, because it's been going on for so long until by the time she seeks medical attention and is diagnosed appropriately, there's been substantial damage done to the heart, this slow burn. And here is the interesting part. Not only do women not recognize it as a symptom of heart disease, doctors don't either. So that
is just amazing.
Isn't it amazing? Doctors don't either. In fact, only 22% of primary care physicians stated in a survey that they even feel comfortable treating a woman with heart disease. And only 42% of cardiologists, we're the specialist.
Okay. That 22% I can believe, but the 42% of cardiologists
think about
are only comfortable or not comfortable treating women.
Yeah, only 42% say that they're comfortable treating women. So 58%, most of them are not comfortable. But when you think about that, it's because most cardiologists are men.
Yeah.
And they are not comfortable. And then you factor in menopause and symptoms, of which there's absolutely no consideration. Let me just be the first to say it. There's no consideration for that in cardiology.
Yeah.
And we're sort of in this big gray unknown zone, but it shouldn't be that way. It's very clear, and we also need to make certain that we're having more research and clinical trials such that it can become even clearer as to what's going on.
Absolutely.
Yeah.
Absolutely. So in terms of that slow burn, could a woman have a heart attack and not know it?
So, you know what? That is such a great question. And the answer to that is yes. That's why it's a great question.
Okay.
Because many times when a woman seeks medical attention, finally, for these symptoms that have been nagging her, it turns out that we see a history or evidence that you've had a prior heart attack, of which you didn't know about it because you had these symptoms.
Yeah.
You didn't seek medical attention. You had the heart attack. It kind of remodeled on its own.
Okay.
Now here you are with other symptoms, and we discover, hey, when did you have a heart attack? And the patient, of course, says, I've never had a heart attack. I'm like, yes, you have.
Interesting.
We're looking at this.
What shows up on someone's, medical information?
So on their EKG.
So it's the EKG.
And then that would drive you to get an echocardiogram.
Yeah.
You can certainly see wall motion abnormalities of the heart. But you can see it also on the EKG tracing. I mean, that's just kind of the baseline to say, looks like you had a heart attack. We can even tell you what area of the heart that it's in. And then the echo we would do just for confirmation. And she may not have realized. Now, what happens is you've had a heart attack, you've recovered, and even though you feel that you're normal, when we actually sit down and talk with you, it starts to become clear that you actually have modified your life over time to adjust to this newer low ability of your heart to pump. And you say, no, my life is normal. And you say, I do everything that I want to do. Okay, what do you do? Well, I walk 4 miles a day. It's like, 5 years ago, did you walk 4 miles? 5 years ago, I used to walk 10 miles a day. And they don't realize they've made these adjustments or those kinds of things.
Very interesting.
And so their lives are moving on normally, but they have scaled things back over time without realizing it. And then when you sit down and talk with them and you really start to put a timeline to it, you say, your life actually is very different today than it was 5 years ago.
Right.
When I'm asking you these very specific questions, you actually are less active than you used to be. And a person doesn't realize it. It's gradual, right? If you used to walk 10 miles, One day you start to walk 9. The next year you're walking 8.
Sure.
You don't really even realize it.
Nope.
And you're still patting yourself on the back for walking 4 miles a day, which is obviously absolutely great.
Sure.
Except when you compare it, we're actually trying to look at what the differences are. And we say,
Interesting.
this is when you were having your heart attack.
Wow.
And you scaled back, not realizing that you've actually made adjustments in your life and lifestyle.
Okay. So how do we then not, let's just say for a non-medical term here, freak out?
Right.
If all of a sudden I'm having jaw pain and I know this and I go, oh my God, maybe I'm having a heart attack. How do we know? Do I call the dentist or do I call my cardiologist or do I call an ambulance?
Yeah. You seek medical attention first.
Okay.
You seek medical attention first. And the reason we're not aware of these symptoms is because women's symptoms are called atypical.
Yes.
There's this word called atypical, which just really grates at me deep in my core.
Oh, yeah.
Because the connotation is, it's not as important. It's not mainstream.
Yep.
It's not the main thing. The main thing are these symptoms that we see in men.
Yes.
These other symptoms, if you learn them, good. If you don't,
Don't worry,
not really
it's
that important.
atypical.
They're atypical. They are some deviation from the norm. They
Yes.
are, not to be concerned with.
Yeah.
They are not common. This whole word atypical, this is what it means.
Right.
This is the behavior. It drives behavior. Words are important, and it drives behavior. And
Amen.
doctors are not immune to that behavior and our training. And then general society, women and men who are not physicians, just general people in society, also only learn the main symptoms, right? The crushing chest pain, the shortness of breath, you start to sweat, you collapse, 911, there's the heart attack, everybody knows about it. Pain in your left arm, nobody ever hears about the other symptoms, right?
Yeah.
But those other symptoms are more frequent in women.
Right.
And women make up 51 to 52% of the population. So how did we end up with the atypical symptoms? Sounds
Thank
like
you.
we're having the normal symptoms. We're having the main symptoms.
Yeah, how about
And it's
the other ones are
men
atypical?
that are having atypical symptoms. And that's a reflection of the male dominance of science and medicine and clinical trials that always enrolls men, and then we get this information and then we just extrapolate it to everybody else.
Yes.
Yeah, hope it works for you. Good luck with that. That's
Good
how
luck.
medicine is practiced in America, even today. That's how it's practiced, which is very unfortunate. We're trying to change that, not just for women, populations of color as well.
Well, yeah.
Nobody's included. It's just white men. Everything is built for them.
Yeah.
And then the data goes before the FDA. It's approved. And now it's prescribed to everybody. But the majority of the world are not white men. So
Really interesting.
It's so women are shortchanged,
Yes.
and we have things prescribed for us that are not for us, and on which we have no data about us.
It's kind of unbelievable we're still here.
Right. Amazing.
Yeah. What's happening? I know you're at the forefront of pushing research
Right.
that does put women in the typical
Right.
and women of color in the typical rather than the atypical.
Right.
What kind of progress have you seen happen there?
Actually, there has been some progress. I cannot say that there hasn't been.
Yeah.
And people it's not just me. I think other people have kind of been beating this drum, but
yeah.
we've been beating it a long time. I
Sure.
mean, probably for 15 years I've been talking about this.
Yeah.
But it's finally starting to gain some traction. And I think COVID was helpful in that.
Oh,
and,
good.
Because people were reticent to take this vaccine, and populations of color were especially hesitant. And when I talk with pharma companies and vaccine companies, I would say, I can help you with this, but I've got to have data on these populations.
That's right.
And they probably were the first ones to really step up to aggressively begin to recruit people because they understood how important that was. And people like me and other doctors, it's hard to sell something If it's not about you, I don't have any data on
That's
you.
right.
So, and to a population that already is very, doesn't feel safe within the medical establishment,
Right.
feels even less safe with research.
Yeah.
So I think the vaccine companies were the first ones to actually propel this forward.
Okay.
And now other companies are moving forward. The FDA is starting to make noises. They have not given a mandate,
Yeah.
but they're making noises. They issue things like recommendations.
Yes.
We recommend. It's not a requirement.
Right.
But it starts to have you read the tea leaves to say, this is the direction the FDA might be going in.
Right.
They've issued these recommendations, even though they're soft. Maybe as a company, we need to start to adjust such that if this becomes a requirement, we're not scrambling. And so more of the companies have started to read the tea leaves to say, oh, FDA recommendations. It's not required, but maybe they're soft pedaling it and letting you know that it's coming.
I see.
So we'll see. We'll see what
Okay.
happens. Women, of course, we have some better representation of women, but what we don't have is studies that are specific to women.
Yeah.
We need to have those. We need to have funding that is specific to women. Now, we've got some
Yes.
improvement. The First Lady, Jill Biden, just got some NIH funding.
Yeah.
But NIH funding is not the majority of research. And we even still got a sliver of that NIH funding. So it's a little bit of a little bit, but we'll take it, right? So we're getting started. And we've got
a start.
That's right.
It's a start.
That's right.
Yeah, we are not satisfied.
We are not satisfied, but she's high profile. We're moving this forward. We need leadership. We need people who are leading these trials,
Yeah.
people of color and women who are actually leading these trials, such that it's not all white men leading study sites, leading study organizations
Right.
and medical establishments. And, here's something else that happens. And, I'll tell you even from personal experience, you're in one of these research organizations and you are leading the research. Ultimately, especially if you're successful, you will be moved to the side. This is really a white, male dominated. Now, you won't be fired.
Okay.
There'll be a series of reorganizations. And your role will just move off. And suddenly other people's roles will be elevated and yours will be increasingly marginalized. Not only is that unfair to the person who is incredibly trained and talented and knowledgeable and passionate, but it's also unfair to society because then business as usual just keeps going.
That's right.
That's the
right.
real problem. Not only have you negatively impacted someone's career personally just because they didn't fit the paradigm, but you also have continued to negatively impact the people that we say we're here to treat.
Exactly. It's the
Right.
microcosm of the macrocosm.
There we go.
And it holds us back in terms of evolution.
Right.
And making, basically forward progress.
That's right.
And in being a more equitable
That's
society. And I believe that our country should be leading that charge. The land of the free, the home of the brave. We should be leading that charge.
We are leading business as usual.
We are leading business.
We are leading.
Yes.
It's just business as usual. This is how it goes.
Yeah, but as women, we are the consumers. And I believe we are also...
And we're the drivers.
We're the drivers, we're the consumers, and we're the consumers of our healthcare, too.
Right.
And with that huge gender gap in healthcare, we've got to have... I feel like we need to have these conversations every day, which is why I'm so happy to listen to you all day long, because the information you provide is really like almost... It's almost mind-boggling to me that we don't know the symptoms of when a woman is having a heart attack, or that a woman could have had a heart attack and not even know it.
Right.
Or, like I said, Dr. Somi Javed's mother's story of basically being told it's all in your head until it was a quadruple bypass.
That's right.
I mean, that's
Imagine that. And even when women or people of color like myself and others are in sort of positions of power or positions at least of succession planning within a power structure, it's very difficult to be just one voice. To speak up means to challenge in their minds. They feel challenged.
Yep.
To speak up means to go against
Right.
the norm, and you do it at your own peril.
That's right.
You do it at great risk.
Yep.
Even though it's the right thing to do, and then you suffer the consequences if you're trying to do the right thing. So it's sort of like, do you stay within the system just to be there, or do you speak out on behalf of patients and risk being moved out? And I think women and people of color are always in those situations.
Yeah.
Always. You don't know whether to keep your head down and just go along and be a good girl, or do you speak up for people who are voiceless and for people like yourself and try to move that needle just a little bit and hope you don't get dinged for it. Right.
Look, it's a tough question.
It is.
It really is, because it comes down to, if you have that fear, and if that fear then puts the security of your family at risk.
That's right.
I would never say to someone, oh, why didn't you stand up all by yourself and stand out there like the lone gazelle?
That's right.
Right? And that's what happens.
The gazelle in a field of lions.
That's right. Right? And if you're standing alone, you're just prey.
Right.
You're just prey, which is why I was so excited by the event at the Menopause where we met.
Oh, my God.
And so excited that the Swells leadership put that together and brought such phenomenal leadership and intellect and authority all together, because that's the kind of power I think will really shift and really move that needle.
Right.
Because then that's not you out there alone, me out there alone, right? Dr. Malone out there
That's
alone.
Right. All alone.
We are standing together.
And it's so nice that we're starting to develop this community, because that's the problem. We are alone, and we have to make these choices all of the time. And it's not just people within the menopause society. It's just women in business, women in medicine.
Thank you.
Women who are intelligent and knowledgeable and experienced and educated, and you're in roles, and you always have to make the decision of, am I going to go along with it? I have a family that I need to maintain, or am I going to try to move things forward with progress, but it will be at my peril and at my detriment.
Yeah.
Or it could be.
Could be. Yeah.
So there's a risk. You're always taking the risk. And women constantly make those decisions. And here is one of the issues with that, is that there's something called weathering in women.
I was about to bring that up.
There is something called weathering. It's the chronic, unrelenting stress of having to navigate and negotiate society at all times.
Yeah.
And it is a term that really was brought up for blacks and black women, but it really applies to all women. And it's the decrease in your quality of life and your quality of experiences over time, the feeling of being always having to look over your shoulder. You're never just comfortable, like a man in a suit sitting down and owning the room. Constantly have to look over your shoulder.
Yeah.
And over time, it causes chronic inflammation in your body. And what is chronic inflammation? It is the cause of heart disease.
Yeah.
We now know that.
Yeah.
So these are real issues that we talk about with regard to women and the navigation of their careers, because it creates a weathering effect that creates a chronic inflammatory state in your body that increases your risk of heart disease. And we move on, and we've seen that now in black women with life expectancy.
Yeah.
It's 6 years less than that of white women because of this weathering effect, but no woman is exempt from it.
Yeah.
And so when we talk about menopause and the increase in your risk of heart disease, really starting with perimenopause. So when you're in your early 40s and those estrogen levels start to decrease, and you start to have symptoms and people aren't really taking it seriously, and even you yourself are, I just have to suffer through it.
Sure.
What can be done?
I should eat
There's
better.
nothing to do.
Yeah.
Yes, exactly.
And you put it on yourself.
Put it on yourself. There's nothing to be done. You may see a physician. You get the proverbial, pat on the back, the there.
Or the antidepressant.
Or the antidepressants. In fact, during menopause, the highest rate of antidepressant prescriptions.
Which is not surprising at all, because you talk about doctors being menopause trained.
Right.
And, one of the big questions I have for our audience is, what can we do to take measures basically so we don't have a heart attack and not know it, or be in need of that quadruple bypass and have it be too late, or have that first heart attack be fatal? What can we do? Who do we see? So if I go see my annual, if I go in for my annual and I say, well, I'm in perimenopause and I'm having some jaw pain and I'm having some back pain and I am chronically tired, what do we do? Do they refer me to a cardiologist?
They should immediately.
Yeah. Okay.
But here's the flip side of that as well. When you probably shouldn't see a cardiologist.
Okay.
And the reason you do is because nobody knows anything about perimenopause and menopause. And the
well, that's what I was going to say.
The reason nobody knows about it is because we're not ever included in clinical trials.
Right.
And the reason we're not included in clinical trials is because we're never in leadership positions in research. And the reason we're not in leadership positions is because, so you see how it all just feeds on itself.
Oh, it does.
So we have no information. But here's something to think about, just the flip side of that, when it's probably not cardiac disease. You're 42, you're 43, you're 44, you start having palpitations. Heart is beating fast, and am I having a panic attack? What's happening? You finally see a doctor, they refer you to a cardiologist, you have a whole big workup, nothing can be found. They may give you a diagnosis of mitral valve prolapse. This is such a common garbage diagnosis.
I got that.
Yeah, there we go. We all have mitral valve prolapse. All women at 43 get mitral valve prolapse. Amazing.
Okay.
So you got a little mitral valve prolapse.
All right.
Right. So you might get, maybe, a type of antihypertensive, which is, is called a calcium channel blocker or beta blocker, maybe. Or, maybe you're having panic attacks. Maybe you need to take a vacation. But here's the thing. It's probably related to dropping estrogen levels. And if somebody would just address the hormone replacement therapy, the symptoms would resolve and you would feel more comfortable. But nobody thinks about that because nobody knows about it. Nobody knows about it because nobody studies women. People only study men who don't go through menopause. Let's even talk about why it's called menopause. I don't know. But they don't even go through it. So it never even comes up. In studies, think about that. Even women in their reproductive years, you're doing clinical trials. There's no menstrual history. There's no pregnancy history. There's no menopause history. But they prescribe these to women just like they prescribe it to women. It's just to men. It's insane. It's insanity that this is how we live, but that's how we live. So palpitations are a great example of the flip side of that, when you probably don't have heart disease.
Okay.
You probably have dropping estrogen levels.
All right.
Now, that being said, whenever you have something with your heart, definitely see the cardiologist, have the workup. But if it's negative,
don't stop there.
Don't stop there. Now, first, let's make certain that it's not something. It could be something.
Sure.
So, and palpitations can also be symptoms of a heart attack as well. So, do not ignore palpitations. But once you've had your cardiac workup and it's completely normal, and we start scratching our heads and talking about antidepressants and antihypertensive medication, it's time to see a menopause specialist, because now it's time to really manage the hormones. Now, I'm hoping that at some point cardiologists will do this. This should just be part of the lexicon of cardiologists.
Well, absolutely.
You've got a woman in her 40s who comes to you with new onset palpitations. Perimenopause and menopause needs to be an immediate part of the differential diagnosis.
Yeah.
This is not hard. This is not hard at all.
No.
But we're not trained on it at all.
No. It's not part of medical school.
No, not at all. Not at all. Zero. Zip, zip, zip.
So is that like the AMA, like the American Medical Association? Is it kind of pointing towards them and saying, hey, we need this mandate?
That's interesting. They would certainly be a powerful lobby, and we have started to move towards having training and research in medical school and training in health equity in medical school, cultural congruence in medical school.
Okay.
And now how much that is translating over into menopause, I'm going to go out on a limb and say not much. Probably not.
Let me take a stab in the dark here. Let's go with next to none.
Right.
Yeah.
Right. So I would say we're starting to move the needle in the area of people are starting to say, hey, what about this other group of people? Hey, what about this other group of people? So that's opening the door then to talk about menopause and talk about, I don't think we're there yet, unfortunately.
I wish I could flip the switch and basically have our heads of everything, whether it's the AMA or the NIH or the government or every other government agency and every company, basically look like the Barbie movie, where it's just women in charge, and therefore we are thinking about that.
Right.
Because I don't want to put the blame on men, on white men, on all men, because they're not thinking about it, because it has just been business as usual.
It's business as usual.
And it has to take, basically, I think, a whole pack of us, not one of us standing out there alone, but a whole pack of us going, oh, hey, listen, this is a little askew, you know, and basically all we're talking about.
And it's been a little askew for about 200 years.
For about forever.
Right. Because the other question is, what's the hurry? Why are you moving so fast?
Well, you know what, I think, I have to quote Dr. Javad here. She said, so women stop dying.
Yeah.
And so black women stop dying.
Yeah. What do you mean, what's the hurry? We've been waiting 200 years. How much longer would you like for us to wait?
How many more of us would you like to die?
I know.
And that weathering
But that's
thing
because
is so
it's
real.
new to them. They just heard about it last week, and they're like, oh, whoa, what's the rush? You just told me about this Wednesday. You know?
so that's like,
right.
I'm going to need some time to process.
Right.
How much time would you like?
Right.
Yeah.
Another century, maybe?
Oh, boy.
Would you like another century?
I didn't know.
And see, this is why women in leadership, in positions of power, don't exclude anyone. They just widen the field and bring people in, as opposed to men oftentimes have to make a conscious effort, which is good if they do it, make a conscious effort to think of something outside of their own realm, because their whole world, society revolves around. It's not normal.
Yeah.
They're not accustomed to thinking about something that deviates from that, as opposed to women and people of color are accustomed to thinking about everything. Our experiences are different.
That's right.
And so just by having someone in, that lens opens. It doesn't exclude anyone. It just broadens it.
Oh, yeah.
And you know, I don't know what the fear is of that. Somehow,
I think it's change. I think it's change. And then the fear of basically all of us fear change, like, oh God, what if? And it threatens our existence. It threatens our stability. It's like, this thing that I know is better than the thing that I don't know.
Right. And not only this thing that I know works really great for me.
Exactly. And what could happen to me?
Works well for me.
Yeah.
If I do something else, will it work less well for me?
Yeah.
So it's kind of like, like you said, that self-preservation.
It is, which is hormonal, really. I mean, that comes down to our early selves, where it's just, we are in it for ourselves, just to survive, and I'm going to make it, you know, outside of the viewpoint of the lion, and you're not. Right. But
I just have to run faster than you.
Exactly. Right. And that, to me, is really about, like, the evolution of our thinking, of our consciousness, of where I do believe that our country should be at the forefront of, look, what we stand for is equality and freedom.
Right.
And therefore, if I do have the right to speak up, then you better believe I'm going to do it.
Right.
And I'm smart enough also to know that I shouldn't be up there all alone.
Right.
That I should be there with all of my sisters. And that is something where I think we can take a note from our patriarchal history, because men have been so good at doing that, and so good at having
That's right.
those roles
That's
kind of
right.
move up in the
Having
ranks.
each other's backs, moving them up,
Because
pulling
that's
from their
very
own ranks.
self-protective.
Right.
It's self-protective. And that's what I believe we've got to do.
That's right.
And then actually prove it in kind of a proof of concept way of like, hey, look at this. You're still good over here, guys.
Right.
You're still good. But you know what? Now that we're better, your lives are better.
We are better. We are better. And why must you lock arms and sing Kumbaya? It's just, we don't really need to do that.
We don't need to do that.
We've got all this talent over here
Yeah.
that actually is going to make you better.
Exactly.
It's going to make you a better physician, a better person.
Yes.
Think about all the misdiagnoses, non-diagnoses of women, and men say this doesn't matter to you. Yeah, it does matter to you. You've got a wife, you've got a sister, you've got a daughter, you have a mother, you have cousins. This matters to you in ways that you're not thinking about.
Yeah.
That's going to negatively impact you.
Yeah.
But
And
it's hard.
it is hard. And you've said this statistic about women are at greater risk of heart attack after menopause.
Imagine this. So,
than men.
before menopause, our risk, because of estrogen.
Because of estrogen.
Estrogen has a cardioprotective effect.
Yeah.
Estrogen is anti-inflammatory.
Yeah.
Inflammation is one of the causes of heart disease.
Yeah.
So if we lose estrogen, we increase inflammation in our bodies. And inflammation is not just heart disease, it's cancer, it's autoimmune diseases. We have
Joint
to think
pain.
about joint pain,
Yeah.
chronic inflammation. And so as we are moving through menopause, before menopause, our risk of heart disease is about half that of men, 50%.
Okay.
As our estrogen levels drop through perimenopause, our risk starts to increase. By the time we hit menopause, our risk is equal to that of a man. But our symptoms are not the same often. But our risk now is equal. And then, just to make it fun, as we go on the other side of menopause and get into our 60s and 70s, our risk of heart disease actually surpasses that of man.
Yeah.
Just to add a little bit of, humor to the entire situation.
Just a little bit of gallows humor.
Right.
Yeah, definitely.
And that's why hormone replacement therapy is a great conversation to have. Menopausal hormone therapy, which is also another term that they're being used for it. It doesn't mean that it's right for everyone, but it does mean that everyone deserves to have the conversation with their physician.
Absolutely. And so how would you define that? Because there's so many different ways of addressing hormone therapy. And I think to your point about terminology, knowing the words, language is important. Bioidentical hormones, menopause therapy, hormone therapy. How do you describe what you just said?
So the way that I would describe that is we generally, this is very high level, are talking about estrogen, progesterone, and in some cases testosterone, which can be very important for libido, for sexual health. You need to have the conversation about all three. All three may not be right for you. If you've had a hysterectomy, you probably don't need progesterone. You maybe only need estrogen. If you have a personal history of breast cancer, estrogen might be contraindicated in you. Not a family history, as people like to think, but it's really a personal history. So that's why you have to have these individual conversations. Also, depending on your symptoms. Symptoms are not innocuous. So hot flashes are not, ha, so funny. Look at her sweating. We now know that hot flashes actually correlate with heart disease. And the more severe your hot flashes are, the greater your risk of heart disease. Hot flashes actually correlate with the degree of lack of elasticity of your arteries and arterioles, so they're not dilating. And you get these flashes. The reason they're not dilating is because they're a little stiffer than they should be. So that is giving you an indicator that you've got an increased risk for heart disease, sleeplessness, insomnia, Everybody suffers, and you either have difficulty going to sleep, or you have frequent awakenings, or your sleep is of poor quality.
Right.
We know that independent of menopause, just insomnia in general, for any sex, any race, has nothing to do with menopause, increase your risk of heart disease.
Right.
And so now, during menopause, insomnia is one of the main symptoms. So now we've got hot flashes, increasing our risk of heart disease. We've got insomnia, increasing our risk of heart disease. And just, again, to make it just a little bit funny, our lipid levels also start to go up. So our cholesterol level starts to increase as well, which increases your risk of heart disease.
Why does that
we start
happen?
to put on weight to add another little layer.
Log on that fire.
And so it could be, when we talk about statin therapy and lipids, that we need to do a balance between whether or not you should have menopausal hormone therapy as opposed to lipids when you're in that perimenopausal, those early years of 40s. Right. These are the kinds of conversations that are fairly sophisticated, and doctors are unprepared to have them. Not because we're unable to learn it, but because we don't really know that the conversation needs to be had.
That's right.
Nobody knows, should we be having another conversation? We don't know about that. That's when the menopausal specialist comes in. It's really, really important to find somebody. Again, and I want to be clear, if you're having heart symptoms, please see the cardiologist. Get worked up. Make certain that is ruled out first.
Absolutely.
Okay? Because we want to rule out the things that could kill you. So
no doubt.
Rule it out.
Yeah.
But then when they find nothing, it's time to see a menopause specialist, especially if you're in your 40s and 50s or even late 30s. It's time to go to the next step, and don't wait for your doctor to recommend it, because he probably will not.
Exactly.
She actually also may not, but he is definitely not going to recommend it and still isn't aware of it.
Let's talk about the term menopause specialist.
Yes.
Because when I think about menopause specialist, that's not something where, if you're somebody who wants to be a doctor in life, and you're like, well, I'm going to be an orthopedic surgeon, I'm going to be a cardiologist, I'm going to be a gynecologist. Nobody right now is saying, I'm going to be a menopause specialist. So it's something that a gynecologist could be.
Sure.
A menopause. A cardiologist could be a menopause specialist.
Really should be. Absolutely.
I believe a gynecologist should be too. 100%. But also, you're having some people that are doing integrative medicine, and functional medicine that are menopause specialists. How do we find a good menopause specialist? How would you instruct someone on a very basic level? Here's the kind of training they should have. Here's the kind of questions they should be able to answer. How do we find that? Because that, unless I'm mistaken, is that a certification?
This is a certification, so it's not a specific formal training. It is a certification where you have gathered and gained extra knowledge very specific to menopausal hormone therapy and menopause and those symptoms. That is not taught in medical school. It is also not taught in your training. So it is not a specific specialty. It is a certification that any specialist could have if they're interested in it. But most people who are interested in it are the OBGYNs because they treat women. And I am a proponent of the cardiologist should all have it, unless you have decided you're going to have a practice that is only men. If you're only going to see men in your cardiology practice, then fine. But if you decided that you're actually going to see everyone in society, you probably should have. Now, it doesn't mean that if your doctor is not certified, that they're not capable of treating it. The certification just lets you know that this physician is interested in it and has gone the length of making certain that they've got a formal certification. Now, you don't necessarily need it. If your physician is interested in it, has taken it upon themselves to learn it and is practicing it, but that's rare. So even now, we're sort of on the cutting edge. We're pushing this forward to be certain. Look for someone who has this certification, because the average physician, certainly no cardiologists that I know of
Yeah.
have this interest and are practicing in this way.
My goodness.
Yeah. That's what we're here. That's why we're here, to push that and to try to make it change and to make certain that people understand.
Absolutely.
And currently we still have to advocate for ourselves, but I envision a world where maybe we don't have to advocate for ourselves. It's just normal. And when you see a physician gives you all of the information that you need as to encompass the whole woman.
Yeah.
And not just this section of the extrapolation of what we learned about men.
Exactly.
And we're extrapolating it to you, and the rest is kind of just a blind spot. I'm
Right.
not really sure what's happening. Here's an antidepressant.
Yeah,
Right.
yeah, a blind spot. We should not be a blind spot.
Yeah, women are a blind spot.
And we shouldn't be an extrapolation. Most definitely. Most definitely not. Well, I do hope too that we don't have to kind of fight as hard. But in the meantime, I'm a big believer in we've got to get the education ourselves. We've got to seek out people like you and get the information from you so we can advocate for ourselves, so we can actually say to our doctor, let's say somebody's been my doctor for 20 years, I'd really like you to get this certification because I want you to stay my doctor.
Or, I really like you, but I think our time together has passed.
Well, okay, that
we
too.
have gone as far as we can go together.
That's right.
Because now I'm in another phase of my life and you're not up to date on it. So
You're
I
not
like you.
qualified.
We've done great, but we've got to part ways here.
That's so true.
And
Because
and
really they're unqualified at
That's
that
right.
point.
They're unqualified for it, and you have to. There's no reason to get upset and leave on bad terms.
No.
But, I do a whole
No.
sterile chronicles. I do these things where I sit on the steps and I talk about medicine in these 60-second blocks. I've
Yeah.
done quite a few on menopause, and I've done several actually, where I literally say, if your doctor doesn't want to talk with you about menopause, what should you say? And I hold up a card that says, bye.
I was going to say goodbye is pretty
Bye.
much the only answer I can come up with.
Don't accept the they're there anymore. Don't accept the, you're just stressed. Why don't you take a vacation?
Yeah.
What's going on in your life? Let's talk about it. Do you need to see, a counselor? All of that may be true, but
Right.
maybe it's being driven by the fact that the doctor is not hearing me and seeing me. Maybe actually my interaction with the doctor is driving me to a counselor because I know something's going on and nobody can hear me and nobody can see me.
It's amazing.
Yeah.
It really is amazing. And if we were, let's say, 10% of the population, I could understand this
Right.
more.
Right.
But with over half of us here, it's
Right.
kind of like, okay, hold on.
Right.
Hold on, because I know I've been in the doctor and said, these are my symptoms, and the questions back have been, how's your marriage?
Right. Isn't that crazy?
And it does kind of make you feel like, wait, am I nuts?
Right.
But it most certainly makes you feel like you're not important, and that your health isn't important,
Right.
And that it basically
And
is
that
like
you're being minimized.
You're being minimized.
That's
Like
right.
you need to go work harder at home,
Right.
in your marriage. Like that just feels like, what century am I living in?
Right. It's very condescending. And I don't think it's condescending purposefully. Now I'm defending a little bit of my compatriots a bit.
Oh, I wouldn't say it's intentionally.
Yeah, I think we have nothing else to offer.
I agree.
We don't really know. We did all the tests. I did everything I was supposed to do. I ordered
agree.
every test. I did everything.
I absolutely
All
agree.
I can tell you is you don't have heart disease. I think, I don't know. How's your marriage? I mean,
I totally agree. I totally agree.
I think we're lost. We don't have anything else to offer.
Yeah.
And that's why we got to have this menopause conversation, because you actually do have something else to offer. You just haven't learned about it.
Yeah. So you talked about estrogen possibly being contraindicated in those who have had a personal history of breast cancer. What about if you've had a different form of cancer, like let's say colon cancer or liver cancer? How about estrogen then? Is that still contraindicated generally?
And so that's a conversation you have to have with your physician and your menopause specialist.
Yeah.
Every single person is different.
Yeah.
And I am a big proponent of hormone therapy, but I'm also a big proponent of it's not for everybody.
Right.
That being said, everybody has to have the conversation because
Agreed.
your risk and benefit may have to be weighed, and ultimately that's a decision that you can make for yourself.
That's right. That's right. Absolutely. And there are the, herbal, right? Made of roots and plants, basically, if I'm saying herbal. Possibilities out there too. Not that I can say what they've done. I've not taken them. But I do see it as my job on this show to bring options to this platform and say, here is this expert that has put this formulation together, and here's this expert who's a big proponent of this for these people, and it all then has to come down to, you've got to see your doctor though, because my chemistry set is different than your chemistry set, and my history is different than your history, and so really, until it does get to that microcosm level, we can't kind of macrocosmically say, oh yes, this is good for all of you women. And that would be so much easier, right? We'd be done with this show in one darn episode. But that's why we're not.
That's right. It's not all. And you bring up a good point, because food is also very important.
Yeah.
And the types of foods that you eat can actually help you manage not only your symptoms of menopause, but also your risk of heart disease.
Okay.
So, and more of an anti-inflammatory diet. So foods that are specifically reduce or combat inflammation in your body, or at least foods that are not pro-inflammatory.
Okay.
So things that are pro-inflammatory, just I'm being extreme now.
Sure.
But
deep fried Twinkies. I'm going to go with State Fair.
Right. And the State Fair is all pro-inflammatory. That's a great way to put it.
Yeah.
That's all pro-inflammatory. So all those kinds of
I'm thinking I was raised in Texas. Are we talking about barbecue?
We're talking about barbecue.
Spare ribs.
We're talking about
high-fat red meat.
Processed baked goods.
Even the not deep fried Twinkie.
Right.
Just the Twinkie.
Just the Twinkie.
Darn it.
Yes. So baked goods in particular are
say it's not so.
It is so.
No.
And the thing you have to think about is that artificial preservatives and things are put into those types of foods to give them a longer shelf life, and it's those ingredients that are also pro-inflammatory.
Okay, I'm glad you said that.
Artificial colorings, aspartame, these kinds of things that give it consistency and texture and shelf life will kill you.
Okay.
So,
Okay, that's good to know. That's very good to know, because that aspartame is out there all over the place.
Right.
And don't we know it's a carcinogen?
Well, not only that, we now have it linked to heart disease as well.
Yeah,
and we see it a lot
those packets are just everywhere. I saw them this morning.
The artificial sugars. It's all fake sugar.
Yeah.
And so all of these fake sugars, which are sweeter than normal sugar.
Right.
And so the irony is, you take these, I'm calling them fake sugars to make it clear. We take these fake sugars because they're 0 calories.
Yeah.
But what we don't know is they've substituted it with another type of sugar and ingredient that is sweeter. And it makes our insulin levels spike. It makes us crave sweeter and sweeter things. And so in the long run, it makes you fatter.
Oh, God.
Because you crave sweeter things, and your insulin levels are now much higher because you're eating something or drinking, like our sodas, 0 calories. So these 0 calorie products actually in the long run increase your weight gain.
That makes me feel better about the Coca-Cola I had last night for dinner.
Just drink a regular Coca-Cola. Drink the regular toxins,
and I'm
not the artificial toxins.
Yeah, 'cause that's actually my drink.
Right.
So I don't drink any alcohol.
Yeah.
But if I'm going to kind of celebrate and
I'm
I don't know.
from Atlanta. I'm from the land
Coca-Cola. I
of
went
Coca-Cola.
to Emory. Yeah,
yes.
exactly.
So
Coca-Cola. You.
There you go.
Yeah, definitely. So I do like it, but it is something that I'm not drinking for breakfast, lunch, and dinner. And I think when we're talking about baked goods, because I hope there is not a day where I do have to give up baked goods, but I like that you said that it is the preservatives,
right,
and it is the things that are increasing the shelf life,
That's
as
right.
opposed to hey, I made this baked good at home with my daughter, we actually made it out of, this kind of heart healthier flour, be it almond flour or whole wheat flour for that matter. And didn't put any preservatives because, trust me, that thing is not going to last on my shelf.
Right. I mean, so it's something like, even, red velvet cake. Is it, and I pose this
like
question.
What's the red?
Is it, if you have a choice, should you have pound cake or red velvet cake? I'm sort of thinking you have pound cake because red velvet cake has artificial coloring in it. Artificial coloring increases inflammation. Inflammation increases heart disease. So if you got a choice, go with the pound cake. So it's kind of, are we down to that kind of level of really thinking about what are we putting into our bodies?
And could we make the coloring like from beet powder?
Yes, you could. Now
I don't know. Red velvet cupcake.
Right. We don't have to be perfect. We just need to be pretty good.
Well, and that's I like saying that because having a history of eating disorders, I think, and I'm going to go with a lot of us have come from that. And I'm going to speak personally here. If I put too many restrictions, that's not good for my mentality. But if I say it like, all right, you know what? This is good for my heart. So I'm going to have this, heart healthy dinner, and then I'm going to have this healthier version of the baked good for dessert.
Right.
I got to go with that. I couldn't ever cut it out completely.
Yeah. I mean, listen, you talked about Coca-Cola. I mean, Coca-Cola has been with me my whole life.
Yeah.
But what I will say is I even have gone further with Coca-Cola. I always mixed a little slurry. So you put orange juice with the Coca-Cola and you have kind of like this orange Coke. And it is just delicious.
Really?
Welcome to the South. That's why our life expectancy is less. So we have Coke is not enough. We've got to put orange juice. We put orange juice
I've not
with
heard
the Coca-Cola.
Of that.
It is just delicious. That's my thing. And it creates a little foamy slurry on top, and
it's kind of fun.
I always make it at home. You never can get it in a restaurant. Nobody knows what you're talking about. But at home, you can pour the Coca-Cola.
What do you
and
call
orange
it?
Juice. I just call it Jayne's drink.
Jayne's drink.
Jayne's drink.
Well, I might be
but
trying
I've had
it
to
tonight.
cut back on Jayne's drink.
Well, yeah, and look, that comes down to like moderation, right? A 2-liter bottle is a whole lot different than a 6-ounce cup.
There we go.
And I think we have to kind of be reasonable with ourselves when it comes to food, because a lot of us, myself included, have that kind of history that then can be a little bit of a trigger.
Right.
And so I have to bring it back to, you know what? Let's go with the 80-20 rule and make sure that we really have those. And I'm going to go, heart healthy is probably vegetables, fresh fruits. I mean, just for people who are kind of like, what is it?
Yeah.
Is it whole grains too? Is it oatmeal? Is it that kind of stuff?
And it's all vegetables are not equal. So there's something called nightshade vegetables.
Oh, I know them.
Yeah.
Because I got a thyroid thing.
Yeah. And the nightshade vegetables are more inflammatory than those that are not.
And so we're talking eggplant.
We're talking about eggplants. Unfortunately, tomatoes, which is my big one.
Peppers.
We're talking about peppers.
Yeah.
We're talking about mushrooms. These are all nightshade.
I didn't know mushrooms were.
Mushrooms are nightshade vegetables.
Oh, no.
So, again, 80-20.
80-20.
Because not only that, especially tomatoes have a lot of positive benefits to them as well. They're pro-inflammatory on one side, but on the other side, they've got all these positive health benefits. So, I might actually do a whole chapter in my book just on tomatoes. I might just talk about tomatoes.
I think you should.
Because it's very, I can't make a decision about them. So I might just put the information in there and you decide for yourself.
We have like a voting thing.
Right.
American Idol. Do you think Dr. Jayne Morgan should have tomatoes or not?
Right, exactly.
Vote yes. Vote no.
Thank you.
Yeah. Well, I think
me.
I'm all for it.
Yeah.
Because I just think the more you know. Plus, I do think that we've got to treat ourselves like our own chemistry sets. So if I just have a tomato with nothing else, just a tomato because I want to test it, and then kind of an hour later go, how do I feel?
Right.
I mean, that's a possibility,
It's a
right? Does my knee hurt, right? Is it causing an inflammatory response? And I've heard
people say, as they've gotten older, as I've been discussing tomatoes with people, it's like, you know what, when I do eat tomatoes, I feel like my joints are bothering me
Absolutely.
now. Or I feel like I have this acid reflux coming up now with tomatoes.
Yes.
So, unfortunately, I'm having none of those symptoms of tomatoes. I love tomatoes.
I do too.
But they're
Love tomato
pro-inflammatory, so I will be honest, I have almost cut them out.
Yeah.
I would, I'm not so strict. If you give me a red sauce, like a tomato sauce or something, I'm at your house for dinner, I'm not going to just push away from the table and I'm not eating this sauce.
Yeah.
But just eating tomatoes anymore, which I love tomatoes, I put them on everything.
Yeah.
So I've pretty much cut back. That doesn't mean I'm not going to bring them back. The jury's still out on tomatoes for me. I'm thinking. I'm
with you on tomatoes.
Right.
I am, because I certainly haven't given up. Like, I love a pasta with so much red sauce. I mean, it's almost like, would you like some pasta with your red sauce? Because I love it.
Right.
Give me a lot of cheese on that. Like, I love that so much. But I have, learned the same thing about tomatoes and knowing they're nightshades. And then that's got a connection to thyroid disease, which I've got. So I'm like, okay, go easy on it. Don't have it every night.
Right.
But like a couple times a month.
I think moderation is the key for everything. I'm just, I'm on this journey of discovering and determining how I'm going to live an anti-inflammatory life. And am I going to be a strict purist, or am I going to have some the 80-20 rule, have some leniency and moderation? And I literally haven't made that decision.
Exactly.
I don't know yet.
Well,
I haven't decided.
I think we make it one tomato at a time.
Yeah, exactly.
And the other thing is, the inflammatory response is not just from food, but also from stress. Am I right?
From stress, from chronic stress. But specifically, I wanted to just talk about food, just to bring up to the audience that there are foods and there is a way of eating that is considered anti-inflammatory.
And I think that does come down to kind of common sense.
Right.
If it comes out of the ground, not in a package, that's probably a good thing to put in your 80 category.
Right. 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 Even though it might be in your 20 category.
It might, if it's a nightshade.
If it's technically.
Yeah. But in general. If it's an apple.
Right.
If it's an orange.
Right.
And again, depending on, you don't know if you're diabetic, if you can't have sugar. I mean, fruit has sugar in it, so everything's different there. But if we're talking specifically about heart and inflammation.
Right.
But the stress part is real for the inflammation too.
No, it really is. And I think, food is medicine, and we've got to think about that with regard to menopause, but also with regard to, sort of our total lives, how we live. So for instance, even during our reproductive years, we could have an increase in heart disease without knowing it if we have certain diagnoses in our pregnancies. If we become pregnant and become diagnosed with something like preeclampsia or eclampsia or gestational diabetes or gestational hypertension, any of those kinds of things, then we, in essence, have just failed our stress test. That's a failed stress test.
Okay.
So here's how an OBGYN describes a pregnant woman. An OBGYN would say, I have maybe a pregnant female in, her third trimester.
Yeah.
A cardiologist might say, I have a volume overloaded female.
Yeah.
Who has failed her stress test. So an OBGYN may say, I have a pregnant female with preeclampsia. That's the diagnosis.
Yeah.
But a cardiologist will see that differently and say, the pregnancy is a volume overload. I've got a volume overloaded patient now who's failed her stress test. So if you are in that situation, you really should move on after the baby is born to getting a stress test, getting a cardiac workup, and moving in that direction to have chronic cardiac care, because your risk of heart disease now is going to be twice that of another woman, and you haven't even hit menopause yet. And in menopause, now your risk is going to increase even more. So that particular demographic is particularly at risk. And it's another reason why we've got to start thinking about food as medicine early, such that all of that can be part of your management as you're moving forward. And you don't just suddenly start when you're 55 and say, oh, well, now I've got to switch my diet. I'm having all these symptoms. No, you need to start earlier, because the less inflammation you have in your body, we have more and more studies that are showing the better or the less are your symptoms of menopause. So for instance, you'll have, with hot flashes, you'll have fewer hot flashes and less intense if you have less inflammation, less inflammatory processes going on. So food is important. Food really is medicine.
Definitely. Now, you've talked about hot flashes, and I've also heard you talk about hot flushes.
So I'm using the term, they are term. I'm using them interchangeably, just like I'm using HRT and MHT. So we're in this transition.
Yes.
All right. So it used to be hot flashes and HRT, hormone replacement therapy.
Yeah.
Now people are saying hot flushes and MHT, menopausal hormone therapy.
Yes.
So I'm using all the terms such that everybody can follow along depending on where we are. And so we're kind of in this transition of moving to this new terminology.
Good. The first time I heard hot flushes, I was like, oh no, there's another thing.
Right. No, it's the same thing. We're just changing the name because it's thought that hot flushes better characterizes what's really happening, because it's not a flash. Sometimes it goes on for long periods of time. So so I don't know who makes these decisions. They didn't ask me. Somebody has power, makes these decisions. So I'm just trying to keep up.
I think you should make all of them.
Right. Yeah, I do too. I do too.
I think you should make all the decisions and teach all of us Pilates
as well. I'm a Pilates instructor.
Which is so cool. And it brings up the other part that's so much about your heart.
That's right. Resistance training for healthy hearts. And the older we get, the more we need resistance training. And people think you need to just really get in there with weights and power through the weights. And that's fine if you're doing that. But Pilates is about using your own body as the resistance and getting those same effects. Plus, you get the stretching, which you don't have with these deadlifts. So the older you get, the more important it is to maintain lean body mass with heavier weights. You will not develop bulk. You will develop more leanness, but you will not develop bulk. And so it's something that's very important. I'm glad you brought that up. And then back to the hot flushes, HRT, MHT. I'm using all the terms interchangeably. It may be within the next year or two, we finally made up our mind which set we're going to use. I think we're transitioning over to MHT and hot flushes. I think so.
It feels newer.
It's newer.
It's newer.
But whether it's going to catch on or not.
I don't know if it's sticking.
I don't know if it's sticking.
Or if there's going to be something else that's going to take its place.
Some other person who makes these decisions.
Exactly.
So I'm just throwing it out there. You have all the terms. But I appreciate you bringing up the Pilates. It's so incredibly, incredibly, incredibly important.
Well, and we think of, what we call running or stair climbing or hopping on this machine or that machine, cardio. How much cardio are you getting? And really, we're talking about cardiovascular exercise, which we tend to think of as running or walking or Nordic tracking or swimming. But really what you're saying is resistance training.
Actually, I am saying resistance training. So we haven't talked about cardio. You still do need to do some degree of cardio, even if it's just walking. And we now know that walking, even just 2 miles, 3 or 4 times a week, can decrease your risk of heart disease. So just getting your heart rate up just a little bit. Now, Pilates is generally more strenuous than people think. Their heart rate gets up more than they think. It's not yoga where you're holding a lot of poses and meditation. You actually are moving through a lot of poses. There's a lot, it's more dynamic, I would say, than yoga, but very similar, but more dynamic. And so a lot of people do get their heart rate up, but you do also need to combine it with something. And I am a big walker. So I'm just telling you, I'm practicing what I'm preaching. I'm telling you what I do.
Absolutely.
I walk. I'm a big walker. And that's what I do for my cardio. And I think I've gotten into walking over the last 20 years just because I was busy as a woman, and it was something that I could do on my own without going to the gym, without waiting for my friend to show up, without waiting for my partner for tennis. I could just get out when I had the chance and move and get back to my house and do it anywhere and fit it in between kids. And it fits my lifestyle.
I'm with you.
Now I enjoy being out there by myself. My mind is just, I'm solving all the world's problems while I'm out walking. When I come back, the world's just a better place. If they had just asked me, I have all the answers.
I mean, my daughter used to say, Mom, could you please go on your walk?
Right, exactly.
And it's like, wow, that really says it all right there. Because you feel it. You feel the difference. So as a yoga instructor, I will just say that not all yoga is created equal. Because if you want your heart raised, just give me 90 minutes and I'll run you through an Ashtanga primary series. Oh. And you might feel like your heart has never pumped harder in its entire life.
So, I should try that. I tried Bikram yoga and hot yoga as well, where you're in these hot rooms. Yeah. Just to kind of see what it was. Yeah. And, I sort of felt like I didn't like breathing the close air.
Me neither. Yeah, that one's not for me.
Like, I was like, I feel like I need better oxygen.
Yeah, my favorite is on a beach.
Okay, yeah.
On the sand.
Outside.
On the beach. I like to have that, feet in the sand and that extra stability, but then also a little bit harder challenge with holding things. But, I mean, talk about, I feel like it's very full body because not only are you really holding your own weight, putting weight on your own joints, but... Woo! Even just the breath will get your heart rate up immediately.
I mean, and yoga is such a great complement to walking, to doing something that's, a little bit more traditionally cardio. And yoga is kind of more in that resistance, but we also need a little bit of something else. Yeah. And I think just combining those is really,
are my two.
Really good. And I say walking, I keep saying walking just because anybody can do it. You don't need equipment. You don't, just walk. Now, it doesn't mean that we all have safe spaces and all of that, so we've got to just kind of think about
it.
But,
like hip pain sometimes, right?
Pain,
like sometimes I'm like, okay, my 4 miles became 3.
Right.
And that's real.
Right.
So it's like, okay, now I'm kind of doing more strength around that and really never taking that walk for granted ever again. Because then when you start to have that pain, you're like, oh, no.
Right.
Oh, no.
Right.
But I think it's just, keeping our bones strong,
and
keeping our muscles strong.
And that's part of the joy of going through menopause as well, that people just, we don't talk about our joints and our frozen shoulder and our hips and everything that's happening.
And that's all inflammation, right?
Right. It's all inflammation. And people, the question is it arthritis or is it menopause? Yes. Nobody ever tells you it's menopause. They tell you it's arthritis. Yes. Nobody ever addresses it in another way, looking at it from another lens to say, what is the whole person? Where is she in her life? How old is she? What should I be thinking about?
Yeah.
This is not a man who's come to talk to me about his joints. I'm looking at a woman who's in her 40s, who's having joint pain. What else should I be thinking about for this patient?
Her dropping hormone levels.
There you go.
Yeah.
We don't think about that.
We don't think about that. We don't. But we are now.
We are.
I'm thinking about it all the time.
Yeah.
I mean, I'm pretty sure you're thinking about it all the time. I think more of us are thinking about it all the time. Right. I think that's a good thing.
Right. And I think the new pause may be having another conference, maybe in the spring or something.
I think it's in Los Angeles.
Oh, is it?
Yes.
Oh, so maybe I heard correctly.
I think
maybe
so.
Okay. So then all of us get together again.
I know. Yeah. And it's great. And I like that we can kind of report back. What kind of progress have you made? Like, I'm excited about what Dr. Lisa Mosconi is doing in terms of the menopause brain and getting more funding in terms of the research there when it comes to our brain.
Right.
And how we can be brain protective too, and think about our brains and our hearts and how all of it is connected.
I mean, it's so many people. Sharon Malone has written her book, Elizabeth Coleman, Mary Claire Haver has written her second book.
Yes.
So there's a lot going on. We've got a lot already. By the time we get to LA, there's a lot of catching up to do.
There's a ton of catching up to do, and there's so much phenomenal information out there. And really, it's a matter of a Google search, to find information and really to see who it is you like to listen to, and what it is you might need to listen to, whether it's your brain or your heart, or all of it,
and how you like information presented to you.
Exactly. But I'm happy that there's places like My Alloy out there, right? Different services for us to go to as well.
Right.
Different products, different ways of interacting with our physicians, different questions we're asking our physicians. I think each and every one of these is a step in the right direction.
Right.
And so I think, overall, even though, with all of the inequities that are there, there's still good news, and there's definitely a lot of hope. And I think a challenge in terms of all of the progress that needs to be made is worthy of the people who get to rise up to it, and that's all women.
Yeah, I mean, we're just going first, so it's hard.
Yeah, we are
pushing it first, but at some point, it'll be normalized for our daughters and our. But
That's right.
We're first.
We are first.
We're pushing this boulder uphill.
Yeah.
For people who are coming behind us, so we've got to recognize that. And it's nice to have found a community. More people are starting to kind of understand and listen.
Yeah.
And we'll just keep developing this groundswell. And
well, I so respect the work you do.
No, thank
I am
you.
truly just. I revere your voice in this space, your voice in healthcare in general, your voice as a woman, and you're just a very important figure, and I'm honored that you take the time to be here today and to fly here from Atlanta.
Yes.
It means so much.
And thank you for inviting me. This was awesome.
I just want to thank our listeners, sponsors, subscribers, and founding members of this show who believe in furthering the field of women's sexual health. If you're loving clitorology as much as I am and want to support our continued mission to bring you intelligent information about women's sexual health from leading experts in the field, go to clitorology.com and follow us on social media at Clitorology. It's my pleasure to bring you the top medical expertise and thought leadership that's furthering women's sexual health at no cost to make sure that you're intelligently informed, because learning about women's sexual health is healthcare. This has been your favorite subject. See you next time on Clitorology.